this is femur, and this is tibia. So right now we are calculating in such a way that we are using the suspensory fixation on the femur side and screw fixation on the tibial side accordingly. So we have harvested the graft, semitic gracilis or peroneus, whichever graft is there, and whatever length is there, forget the length of the graft. Let's calculate of the femoral size. So this is the lateral portal, this is anteromedial portal, right? So now you are from anteromedial portal, you have drilled the ACL tunnel, and with beath pin you have drilled like this. So this is the beath pin. Over beath pin you are drilling with the 4.5 mm reamer through and through, bicortical. So this is a bicortical reaming. That is the step number 2. Now over the 4.5 reamer we have the marking. So when there is a second cortex giveaway, we know how much we have pierced, or we can use a depth gauge and measure the length. So now that length comes out to be 40 millimeter, right? 40. Now the diameter of the graft is 9 millimeter. So now the third step will come is the 9 millimeter drilling. So for an example, in 40 mm tunnel, we want to put 2 centimeter of the graft, 2 centimeter. So we think that we want to put 2 centimeter of the graft. So only 9 millimeter, we will drill 9 millimeter up to 2 centimeter, this much. That is a 9 millimeter, 2 centimeter tunnel. But when we prepare the graft, so this is the graft, and this is the 2 centimeter loop, and this is endo button. So this is 2 centimeter and this is 2 centimeter. So total is 4 centimeter. So when we pull the graft inside, this 2 centimeter portion will come and stop here. At the same time, the button will come at around this region and it will also stop. So button will not flip. So to flip the button further, you need to bring the button out completely here, oblong way, then you will flip and then you pull it back, so it will come on the cortex. So you need to drill around 7 to 8 millimeter more. So for fixed loop 4 centimeter tunnel, we take 2 centimeter or 20 mm of closed loop. So to drill, we will drill around 2 centimeter, 7 centimeter or 8 centimeter more. So that will be 27 or 28 millimeter. But to make it easier, what you can do, total length of the tunnel is 4 centimeter. You do 4 centimeter minus 1 centimeter, 10 millimeter is equal to 30, round figure. As he mentioned, there should be at least 1 centimeter of the outer cortex remaining to avoid the blowout of the tunnel. So 4 centimeter minus 1 centimeter. So you drill up to 30. Now you forget all of these things and આખું એક સાથે ઇરેઝ કરવા માટે શું કરવાનું? Now the question comes when the tunnel is 35 millimeter and 30 millimeter. Short female, short height, 35, 30. Here you want to put 2 centimeter of the graft. So minus 20 is the graft. So the loop you will take is 15 millimeter. Okay, fixed loop 15. So 15 plus 7 or 15 plus 10. So you will drill 25 millimeter. Right? Up to here it is clear. Now the is 30 millimeter. So you can't put 20 millimeter graft inside. Because if you put 20 millimeter graft, the remaining is only 10 millimeter. So you cannot over drill. So in this case, you will put slightly shorter graft. You put 15 millimeter of the graft, 15. So the remaining tunnel length remains is 15. So you take 15 mm of the loop. But if you do 15 plus 10 over drilling, 15 mm of graft plus 10 millimeter of over drilling. So you will drill up to 25 millimeter. Then only 5 millimeter of the outer wall will remain. So the chances of blowout is more. So in such cases, adjustable loop is helpful. So if this is femur and tunnel is only 30 millimeter. So you can put around 2 centimeter of the graft also, and only 10 will remain with the adjustable loop. In adjustable loop, you don't require over drilling. So in such cases, adjustable is helpful. So if adjustable is helpful in this, then adjustable is helpful in 40 millimeter also, 45 millimeter or 50 also. You don't have to calculate. Agar for tunnel length is 50 millimeter, then for 2 centimeter of the graft you require 30 millimeter of the closed loop, 3 centimeter. Sometimes it is there in the inventory, sometimes it's not there. So better you use adjustable.
For adjustable loop, you only need to drill 10-20 mm.
How much ever graft you want to put in the tunnel, you drill. Yes. So that is advantage. But in my practice, I drill little bit more. Now, why? So because on the tibial side, I use adjustable disc. The disadvantage of the adjustable disc is when you cinch, it reaches its maximum limit of cinching. So for an example, the graft is right up to here on the tibial side, and it has cinched maximally. The disc will not go further down and it will not tighten. So if I have over drilled on the femur side, I can further tighten and pull the graft inside, and so that I can tighten on the tibial side. Now we have discussed about the femoral fixation. Now let's about tibial fixation. On the tibial side, there are two types of fixation. One is called aperture fixation, and another is called suspensory fixation. So this is tibia, and this is the outer tunnel opening, and this is inner tunnel opening. This length is usually around 4 to 4.5 centimeter. 4 to 4.5 centimeter. Now in Indian patient, normal graft length which we get is from 7.5 to 8 centimeter after quadrupling the semitendinosus. It is usually between 28 to 32. So 75 to 8. Out of 7.5 to 8, 2 centimeter will go into femur, right? Intra-articular portion will be around 3 centimeter. So 5 centimeter is gone. And if the graft is 7 centimeter or 7.5 centimeter, so you will get up to 2.5 centimeter in the tibial tunnel. So this much portion is empty. Now if you want to fix it with the tibial screw, adjustable screw, so there is a possibility while putting the screw inside, it will push the graft inside the tunnel, or you will not get the adequate fixation here. That is the disadvantage. So you need a longer graft. So to make a longer graft, you will not do the quadruple, but you will do the tripling of the graft. And tripling of the graft will make the graft longer. So around 30 centimeter graft, if you do triple, it will become 10 centimeter. But at the same time, it will be a thinner graft. So the diameter of the graft will become thin. So that's why over a period of time, we have realized that when the patient comes in follow-up, there is some laxity is there, residual laxity, or intraoperatively also after fixing the screw, when we look inside, the graft is little bit loose. So some people have shifted to peroneus longus graft because it is longer also and it is thicker also. So once you triple the peroneus longus graft, it becomes around 10 centimeter, as well as it is thicker also. You get around 8 to 10 millimeter of the diameter. So this problem is solved with the peroneus longus loop and the screw fixation. But if you want to take a hamstring graft, so we have shifted to suspensory fixation, because this 7.58 centimeter is coming here on the femoral side, on the tibial side, both the side adjustable is there. You don't need to get the full length of the graft, so you get the good diameter thickness. I think all of you have seen the graft preparation, little bit complicated graft preparation, but you get suspensory tight fixation on the both the sides. If the bone quality is bad, you don't need to worry about the aperture fixation. If the graft is short, you don't need to worry about the screw fixation. If the graft is thin, you can make it quadruple, you can take gracilis, make 8 strand graft. So that is the advantage of suspensory fixation on the both the side. But if patient insists for the screw fixation, then we take peroneus. We don't need to worry about the length as well as the thickness. So that is the advantage.
For both the sides, if there is suspensory fixation,
Theoretically, there are two side effects. One is called bungee cord side effect. Like bungee jumping, the cord is stretchable.
but it's only theoretical.
But no, it is there. But if the graft is snugly fit into the tunnel, like we measure in 0.5 millimeter now, 8.5, 9, 9.5, and it is tight on the both the side. That's why if you see on the tibial side, along with the adjustable loop, we use the fiber wire also. So fiber wire and adjustable loop both together will not allow that bungee cord effect. So in all inside ACL reconstruction, what we are doing is not all inside ACL reconstruction. Even though it is called all inside equivalent ACL reconstruction, but in purely all inside ACL reconstruction, there is endo button, pure endo button, and endo button on both the sides. In that case, I think there is a possibility of bungee effect. But we are using very strong number 2 fiber wire. It will not allow to stretch. And in last 4 years, we have done exclusively we are doing this, and we have not seen any bungee cord effect. Another is called windshield wiper effect. When just like this is the tunnel, and this is the graft, and there is a space here, it will move like this, like windshield wiper, and it will cause the tunnel widening. But when you keep the graft a little bit loose, it can happen. So we even 0.5 millimeter increment wise if you go, then it will not be there.